Good evening, folks. I'm Adam Shanley, the MPOWER Programme Manager at HIV Ireland. You're all very welcome to this community town hall talk on monkeypox, organised by MPOWER in collaboration with Man2Man and facilitated by our pals at GCN. So we have a busy hour planned with lots to get through. We've invited HSE leaders in the monkeypox response to answer questions about the response so far and to discuss the next steps. So we'll hear from Dr. Eve Robinson, epidemiologist and specialist in public health, about the kind of current outbreak in Ireland and across Europe, and what we can expect to happen next with the spread of the virus in our community. We'll speak also to Dr. Cathal O'Broin, consultant in infectious diseases. He'll be on hand to answer questions about the monkeypox vaccine itself, how it's administered, and how effective it is, and some other questions too. And then we'll put questions to Kieran Brown. He's the chair of the National Monkeypox Crisis Management Team. So I'll be asking him about the response so far, and I guess the big question we all want answered, which is when will there be more monkeypox vaccine appointments available? So we'll get to that. And then finally, we'll have time at the end to take your questions and put them to the speakers. So please do post your comments and questions in the chat function, and we'll get to them then. So this is a live stream event on Facebook and YouTube. So you may be watching this back, and if you are, thanks for tuning in. But just be aware that any comments that you put in the chat box during the playback they won't be seen by us. So if you do have a question and it's not covered over the hour, and you still want an answer, feel free to reach out to us on socials at MPOWER Programme or through the MPOWER website as well. So for those watching live, we do encourage you to post your comments and questions. And as I said, we'll come to them at the Q&A section at the end. I'll just remind those that are commenting to be kind and respectful to the speakers and to each other. We're holding this space for the next hour or so as somewhere that we can, have our questions answered and to voice our concerns. But it's not a space for homophobia or transphobia or racism or any kind of hate speech of any kind. So just to mention that. So look, with all that said, let's jump right in, and we might bring Dr. Eve Robinson, epidemiologist and specialist in public health at the HSE and Health Protection Surveillance Centre. Hi, Eve.
Hi, Adam. Hi, everyone.
So, so the last time that we had a community talk, we were about 6 weeks into the outbreak in Ireland. And we're now 6 months into the outbreak. So Eve, you're in charge of kind of collating all of the Irish data on monkeypox and engaging with colleagues in Europe. Can you give us a bit of an update on where we are with monkeypox cases?
Yeah, I just have one slide that I wanted to show, just to show visually what's happened here in Ireland and across Europe. So just here on my right, so that the graph with the maroon color, this just shows the number of cases per week in Ireland, and this here in green is in Europe. So just in Ireland so far, coming up to the 6 month mark, we've had 217 cases notified to us. So our first case was diagnosed on Friday, the 27th of May, captured in our system the following week, along with 6 other cases. And while we have had a lot of week-to-week variation, so you can see the graph is a bit jagged, you can kind of more or less see the overall increasing trend up to this point, which is mid to late August, where we had our highest number of cases. And then again, some week-to-week variation, but overall decreasing trend. And the last 3 weeks, we've had between 3 to 4 cases per week in Ireland. In Europe, so this graph is a lot smoother just because it has a lot more cases in it. So you can see although the first case was detected mid-May, we were able to go back and find previous cases that just hadn't been recognized at the time. So the first case with symptoms was mid-April. Then you can see kind of a fast increase till the end of July, so it kind of peaked a bit earlier than we saw in Ireland, and then a sharp decrease. And the last few weeks, just very low number of cases across Europe, around less than 50 cases per week. And just to comment, I don't have a graph, but for other regions of the world, so the Americas, so both North and South and Central Americas, they've been the regions with the highest number of cases. It took off a bit later there than it did in Europe, and it is beginning to decrease, but they still have high number of cases, and it's just decreasing a bit slower than we saw in Europe.
So we're seeing a reduction in cases then. Why do you think that is, and what's kind of driving that? And is it a true reduction in cases, do we think?
Yeah, so definitely when things started to turn initially, particularly in some of those countries that would have had a lot of cases like the UK, France, Germany, there was a question, is this real, or just are people not coming forward for testing or can't get testing? And there's lots of different reasons why people might not come forward. But I suppose as the downward pattern continued, and it was seen, the same pattern was seen across several countries, I think it gave us confidence that it was a real decrease. Now, for sure, we're not capturing everyone, and there's still people that won't come forward to test for testing or can't get tested. But I think while for a lot of people, when they get monkeypox, it is mild, there's a significant number of people that it's not mild for, and it's very painful and uncomfortable, and they will come forward to the health service. So if there were a lot of cases out there in the community, I think they would be coming through to our systems, and we would be seeing them. So I think it is a real decrease. I suppose reasons why we saw the decrease, probably several different reasons at play, and we don't really understand the contribution of each to the decrease. I suppose it really took off at the start of the summer, where there was a lot of people traveling for holidays, and a lot of the summer festivals were happening. And I think people's sexual behavior might be very different when they go on holidays or attend certain festivals. So I think when the end of summer came and those travel and festivals stopped, we saw the decrease in cases. Even outside of travel or going to festivals, some people may have adapted their behavior, so they might have reduced their number of sexual partners, or might have restricted it to people that they know well. The vaccine definitely had an impact. However, we did see that in many countries, the decrease started before the vaccine campaign started, or before it was a widespread vaccine. And in a lot of countries, the vaccine campaign is still limited. So while the vaccine probably contributed, it certainly wasn't the driving factor. And then a certain number of people have already had it and have immunity after being infected already. And maybe particularly men at most risk may have already had it and have immunity.
Yeah,
lots of different factors. Probably.
Yeah, I think what you've been, that kind of community mobilization piece is really important in terms of, we've kind of a good history of responding when the call is put upon us, and I think that has a lot to do with it as well, as you've mentioned. I see the slide is up there, just about what we might expect next, and is it likely that when we see this drop off in cases, is that us approaching the end of an outbreak, or are we in the center of a storm and a second wave is coming? What do you think, and what are your kind of colleagues thinking is going to happen next?
So we don't know for sure what will happen. The European Centre for Disease Control did some estimates to try and estimate how many gay, bisexual and other men who have sex with men may still be at risk, because either they haven't had infection before or haven't had vaccine. I suppose they gave an estimate of between 55 to 95%, which is quite broad, but I think take home point from that is that there are still a lot of men that are susceptible to infection. So there's a few potential scenarios that may happen. One is that there might be a resurge in the outbreak, so we might see a huge wave like we did before during the summer. I suppose the concern what might drive that is that because numbers are low now, that our interest or our activities around trying to stop spread might wane. So there's also a risk that when festivals might restart, that the conditions might just be ripe for it to take off again. I suppose we're all looking very closely at now because there are some winter festivals happening, so we're looking very closely at the numbers to see if that has any impact. Another scenario is that we might just continue at a very low number of cases with occasional spikes or outbreaks. And this is what we think will probably be the most likely scenario. But again, I said we don't know for sure. And I suppose while monkeypox is circulating anywhere in the world, there is always the risk of cases being imported to Ireland. And then subsequent spread amongst contacts of those cases. And then again, particular events might see a spike in cases. So this is what we think might happen. But again, we're monitoring very closely. In terms of it completely waning and going away, it's possible, but I think the conditions just aren't there yet for that to happen. Again, while there's monkeypox anywhere in the world, we're always going to be at risk of it. So
good coverage of vaccine is probably an important key opportunity to get on top of any of those future possible scenarios. Yeah. Okay. Well, I see that there's kind of comments and questions coming in. Thanks for that, Eve. And just a reminder that if you do have any questions for Eve, just to put them into the comment box on Facebook or YouTube, and we'll get to them when Eve joins us again at the end. But thanks for now, Eve.
Thanks.
So now we'll welcome Dr. Cathal O'Broin, consultant in infectious diseases at St. Vincent's University Hospital, to join us.
Hey Adam, thanks so much for having me today. Good evening. The end of the Vincent's Prep Clinic. We just wrapped up there a small while ago, so great to be here.
Yeah, fab. Thanks for making it. Cathal, so look, we've just heard from Eve there that there's kind of a reduction in the number of confirmed cases of monkeypox, but it's still, it remains really important that, people take action if they don't feel right. So can you just give us a quick reminder of what the symptoms of monkeypox are and how and where to get a test?
Sure, definitely. I think we have to acknowledge the contribution of the community to reducing those numbers and getting to that point, first of all, because it's through people identifying their symptoms, coming forward, getting a test, getting their partners tested, getting their partner a vaccine. That's how we reduce the numbers. So it's been really, really fantastic. It's really, really empowering to see how the community contributes to the management of an infection. It's really, really great, and I'm so impressed by all the work everyone's done. So the symptoms that people tend to have, so there's there can be two stages of monkeypox infection. So the first stage is described as kind of a fever or a general unwellness, a tired, muscle aches, pains. It's a very general thing, and I'll be honest, in the context of flu going around, COVID going around, there's another virus, RSV, that a lot of kids get, gives you kind of a runny nose. It can be really hard to differentiate that from any other infection. And I think I only know of one case in Ireland of the 217 that was diagnosed at this stage, and that was because someone knew that they were a contact of monkeypox. It's really not something that we're going to pick up very frequently. Not everyone will develop this syndrome as well beforehand. Not many people won't, in fact. The second stage then is where you get those spots, and I think that's where people start to present and say, look, I got a few spots somewhere, I'd just like you to check them out. The spots typically can be a little bit flat or red at the beginning, and then start to develop, little blisters full of some clear fluid. Then they develop into little blisters with a little spot in the middle, so there's a little depression kind of in the middle of it, a little hole. And later on, those form a little scab, and then they heal thereafter. So those spots, we've seen quite a lot of spots typically in the genital and the perianal area, so around the penis, the groin area, or just around the bum. You might see a few spots there. So someone might complain of a little bit of a sore bum, and they might say, oh, do I have a hemorrhoid there? Could be a small fissure. And then on closer inspection, you might say, actually, there's one or two little spots there. We have to keep an eye on those. But you can get spots anywhere else. You can get them on your hands, your face, your chest, your back. They can present anywhere.
And to get a test, then, if you do start to notice that, how's the best way to reach out and get it booked in for an appointment?
Certainly. So to link in with your local STI service first of all, so it's really good to ring ahead and say, look, I'm a bit concerned that I've got a monkeypox infection. Are you able to support me? So many STI clinics are able to do monkeypox testing. Some aren't, and they're able to direct you to your nearest STI clinic. So we have a service here in Vincent's. There's one in the Mater. There's one in James's. Cork, Limerick do testing. Galway do testing as well. So there's testing across Ireland. But just to ring ahead, to link in, and we'll make sure to get to see you as quickly as we can.
Great. And you're one of the clinicians that kind of has cared for people who have had monkeypox. What can we offer at this stage now that we're a little bit further down the line? What do we know works in terms of treatment for monkeypox?
Yeah, I think we've learned a lot from our experience, and certainly from the experience of our colleagues in the UK as well. And the first few cases that I saw, some of them were very mild, and paracetamol was enough to help. They had a little bit of an itch. Paracetamol or an antihistamine might have helped them. But I think if people develop pain around the perianal area or infection of the rectum, so we call that proctitis, that's when things start to get a little bit more sore. And that's where we really learned from the UK's experience. And I remember when I had my first case here, I rang a colleague in the UK and she was like, oh, this is where we went wrong. This is what we do now. We know this works really, really well. So what we do is make sure to get good painkillers on board. So we've got paracetamol and anti-inflammatories, a nice strong anti-inflammatory, something like diclofenac, which is a really potent anti-inflammatory that we're able to provide in the clinic, give to the patients going home because they don't need to go to a pharmacy. We don't want any extra hassle from that perspective. There's also some creams that work really, really well. There's some creams that have some local anesthetic in them, so help to numb the area and prevent that irritation of the skin or of the mucosa or the skin just inside the rectum. And then we can also use some antiseptic creams as well. And then more potent painkillers if we need them as well, in terms of, if we need to give someone a small bit of morphine to help them with their pain, that's entirely appropriate. People shouldn't be in discomfort at home at all. Really, really important to keep on top of their bowel motions as well, because obviously if you're straining at all, you've got a few spots in the rectum, that can be really, really sore. So we give lots of laxatives just to make sure that the bowels are nice and clear, and it's much, much easier. We do have an antiviral medicine. It's called tecovirimat. It's a new drug for all of us, a tricky one to pronounce. Tecovirimat is, we don't fully understand how effective it is yet, or does it work or doesn't it work. The US has been using it a bit. We do have it here in Ireland where it's required. So certainly if someone has a low immune system, they've got severe rectal pain from their monkeypox infection, they've got a spot in their eye, anything like that, we're able to access that tecovirimat and give them a course over the coming days, and we're able to provide that service in all the major hospitals.
Right, so we've come a little bit in the time, and I suppose when we kind of had this community talk at the kind of start at the outbreak, one of the questions that kind of was raised a lot, and one of the questions that we get a lot when we're doing outreach in the community is, what are the kind of longer term effects of monkeypox, or do we know? And I suppose one of the main questions that we get asked a lot is that, will I be left with scarring? Do we know where we are with that?
Yeah, so many people have only a few small spots, and they heal with absolutely no problems at all. Some people, a minority, may have more spots, and obviously that the more spots you have, or the larger the spots they are, they may heal with a small element of scarring. We've seen some people with scarring, but mostly they heal, they're absolutely fine, and there are no issues. But some people can develop scarring. So we're always here to support the patients as they go through that journey, make sure we keep a close eye on the spots, and provide them with any medication or care they need.
Great. Well, I see a couple of comments in about research and opportunities to kind of understand these things, which we might be able to come to a little bit later. But I want to move on to the vaccine, and I guess a load of quick fire questions for you about the vaccine. Oh, there's Kieran, he's a bit early. Cathal, so first off, are there side effects associated with the vaccine that we?
Yeah, so the vaccine has been around for a while, so we have a bit of experience with the vaccine. It wasn't like the COVID vaccine, which is quite a new vaccine, although we had a lot of data from the studies on it. The vaccine can be given in two ways. It can be given as an injection into the fat of your skin, or it can be given into the actual skin. So we call that intradermal. So just we make a little bleb, or a little kind of a water blister almost, of vaccine just inside the skin. And the most common side effect when you give that little bleb, that water blister, is that it might be a little bit painful, a little bit itchy. And certainly you can take antihistamines, you can take, painkillers for it. We don't recommend putting any, steroid cream or anything on it, because obviously that can reduce the inflammation in the skin that we actually want to be there, which is promoting that vaccine response. But you can use things like calamine lotion and things like that. They're absolutely fine. It does cause a little bit of an itch, I'll be honest, and that's the feedback we get mostly. You can give it in 2 spots, so you can give it on the forearm here, or else you can also give it in the shoulder, just where you would have gotten vaccines as a kid as well. We find the shoulder works a little bit better for some people, because the vaccine can cause a little bit of a paleness or to the skin, sometimes maybe a very small scar in a portion of patients. So some people prefer that to be on the deltoid or the shoulder than to have it on their forearm, which is absolutely fine. All the clinics are trained to do that, and we're happy to do that.
So the kind of the bleb that you have, it's normal for that to be itchy for a little while, and it sticks around for a while, does it?
Yeah, so you can be itchy and a little bit red for several weeks,
Okay.
and you can even have that small bit of paleness of the skin for months after the vaccine. So that's normal, but we're happy to give it a little bit higher if you're worried about that paleness or a small scar forming. It's similar to the BCG vaccine, which some people might have had. It's like the old TB vaccine. They would have had, you see the little TB scar on your shoulder. So it's a little bit similar to that vaccine.
So you mentioned intradermal, which is kind of a new way. I mean, it's new to most of us. So it's into the top layers of the skin, right? And why is that being used?
That's a really good question. So in 2015, there was a study that was looking at the vaccine, the monkeypox vaccine. Now, of course, it's actually a smallpox vaccine, but smallpox and monkeypox are in the same family. So we're using a smallpox vaccine. And what they discovered is that when you gave the vaccine into the subcutaneous tissue, which is the fatty tissue of the skin, and when you gave it into the skin, you had very similar immune responses. And they measured these immune responses out several weeks and months after the vaccine had been given. And the reason why that's really important is that we know that we can give a much lower dose of the vaccine when we give it intradermal, so into the skin. So we use 1/5 the dose. So that means 1 vial of the vaccine. If we give it subcutaneously, that's 1 person. If we give it intradermal, that's 5 people. That's 5 doses. So we're able to really expand the accessibility of the vaccine to lots of people, which is really, really important, because everyone who needs the vaccine should have access to it.
And so when we're talking about intradermal, is there any instances when intradermal is not recommended, or where you should kind of go with the old-fashioned jab in the arm?
Definitely. So there's one instance, is the one that we see probably most commonly, is something called keloid scarring. So keloid scarring is when someone has a history of having a small injury, and they get kind of an abnormal, really big scar that forms that site. So it could be a very small bump or small cut, and you get quite kind of a lumpy scar at that site. And that's slightly more common in certain people. So certainly it's more common in Black people. And where, if someone has a history of keloid, we're happy to give subcutaneous vaccine and to use the whole vial, because it reduces the chance of keloid. It's much, much safer. The intradermal, you can get keloid with that, and we wouldn't want to give that to anyone.
One of the other things that we've kind of been asked as well on outreach is, around getting, so, it's kind of vaccine season at the moment. So there's flu and there's COVID and all the rest. Are there wait periods, or should, can we get them all at the one go, or what's the recommendation?
For sure. So the precautions in general would be, I suppose, first of all, that you shouldn't have a fever when you're coming in for your vaccine. And that goes for every vaccine. We don't want to give someone a vaccine if they're feeling a little bit under the weather, mostly with fever. A runny nose isn't a big problem for us. Secondly, if they've got an allergy to any of the components of the vaccine. So there's a few antibiotics that you can have allergies to. They're very rare by and large. Chicken protein is another one. But again, we don't see many people with chicken protein at all. And then the third piece then is, I suppose, the COVID vaccine. So you've had the COVID vaccine already. There's no problems, but we don't recommend getting the COVID vaccine the 4 weeks after you've had your monkeypox vaccine. So if you get it beforehand, that's absolutely fine. There's no delay, but just to have a 4-week gap if you're getting it afterwards.
Okay, and the flu vaccine is okay to get.
Flu's grand, yeah.
Oh, good. So how long after the vaccine then are we protected from monkeypox?
That's a great question. It kind of links into your research piece that you mentioned already. Mm-hmm. So certainly with the studies we have so far, it's 2 weeks after the second dose that you get the complete amount of protection that you're going to get. Now, that's not to say it's 100% protection, but whatever the vaccine will give you, that's at that stage. But there will be some protection, 2 weeks after the first dose of the vaccine. But really, to get the full protection you need both doses. For most populations, I should say. There's 1 or 2 caveats to that. So it's really great if everyone comes for both their doses. We're happy to give them, of course.
And if you've had monkeypox before, do we need, do we have immunity going forward, or do we need to get a vaccine?
Yeah, so certainly in the short term, we're not recommending to get the vaccine. We know with smallpox that people who got smallpox once didn't get smallpox again. With monkeypox, certainly there's no concern that you get infection very quickly. Over 10, 20 years after a monkeypox infection, I can't say that right now. Unfortunately, monkeypox was an infection that primarily affected people in West Africa and was largely ignored by many people in research. There just wasn't the impetus or the drive to help these people, and that's a huge shame from a global health perspective. But it leaves in this situation where we don't have the answers to every single question. But certainly in the short term, we have no concerns. These people don't need a vaccine. That's great.
And if I've had a smallpox vaccine in the past, I know people in their 50s and 60s may have. Are you recommending that people come forward for monkeypox if they're at risk?
Definitely. So actually, people plenty younger have had their smallpox vaccine as well. And I was talking to a friend from Brazil recently, and in the 1980s, they were still giving the smallpox vaccine in Brazil. I've had patients, from Poland as well, who've told me that they had their smallpox vaccine in the 80s. So there's plenty of people that we see who are quite young and have had a smallpox vaccine. So what we're recommending at the moment is that they get 1 dose. So it's kind of like a booster. So you've had your smallpox vaccine when you're younger, and you get a second dose now. But I suppose it's just important to check to make sure that people did have the smallpox vaccine, because you might have had lots of vaccines when you were a kid. Could have been the chickenpox vaccine, those kind of things. So important to check it out so we have the best information to help you make that decision.
Okay, thanks, Cathal. I think we've covered off a good bit, so people have a better idea of what to expect when getting the vaccine. But if anyone watching does have any questions for Cathal, do put them in the chat and we'll get to them. But for now, thanks, Cathal, and we'll see you again shortly.
Thanks.
So now, I'd like to welcome Kieran Brown. He is the chair and the lead of the National Crisis Management Team for monkeypox in Ireland. Hi, Kieran. You're very welcome.
Afternoon or evening, Adam.
So, Kieran, look, I think we've lots to get through, and we'll speak about plans for reopening. Can you hear me? Yeah, good. Yeah. We'll get to plans for reopening the appointment portal for vaccines shortly. But first, I think it's important that we kind of speak about access to vaccines in Ireland up to now. And we know that gay and bisexual men are disproportionately affected by monkeypox. And we're a small enough community in Ireland, but we're a community that's very well connected with our global queer family, both online and in person. And it's been very difficult, as a queer person in Ireland, to watch on as most of our peers across Europe and the UK and over the water in the US and Canada, they've had the opportunity to get vaccinated against monkeypox, months before vaccines were available in Ireland. And many people in Ireland, have attended Summer Pride across Europe, and we were kind of the odd ones out, not having a first dose. And many people are traveling to Winter Pride now and remain largely unvaccinated. So that's it's been difficult from our perspective. And in addition, I guess, to all of this, we're coming hot off the back of probably the biggest vaccination program the state has likely ever seen. Vaccinating almost every person on the island twice, and possibly more for COVID-19. So, with all of that said, why has it taken so long to get access to vaccines in Ireland compared to our neighbours?
Yeah, thanks very much, Adam. And look, I appreciate exactly what you're saying there. I suppose, first of all, just to acknowledge that the HSE established an incident team back in May 20 of this year, when we knew the outbreak was happening. So I suppose the vaccination program is one part of a large program of response within the HSE. And then within that, with the vaccination program, when we saw the outbreak beginning to emerge and the numbers going up back last May, the HSE went to secure additional vaccine stock. Unfortunately, there was just limited international availability of vaccination stock out there. And at that stage, I suppose, Adam, it's important to point out that when we talk about vaccination, we are looking at two groups. Number one is the post-exposure group, and then what we'll be talking about today is the pre-exposure group. So post-exposure is obviously the part where someone feels that they have been in close contact or have been exposed to monkeypox, either, you know, as part of their partner or a healthcare worker. So it was very, very important from our point of view to firstly secure stock for the post-exposure group to ensure that they had access to some sort of prophylactic post-exposure treatments. So then during the summertime, two things came together from our point of view. We were obviously closely monitoring the peak infections, and the numbers were increasing at that stage. And then, as Cathal had alluded to, in August, the European Medicines Agency advised, excuse me, that we could use the intradermal usage of the vaccines, which gave us a greater ability to use the current stock that we had for a greater population. So at that stage, we began to decide how we could offer the pre-exposure vaccinations to the community. But at that stage, again, just to acknowledge, we only had access to limited stock. We were at that stage, obviously, trying to contact the manufacturer and secure additional stock. And like also other countries, particularly in the EU, were following a similar model. The manufacturer was receiving requests from lots of different EU countries to try and get access to the stocks. Now, we're happy that we have secured that additional stock in. The original actual scheduled delivery for the next stock was actually in December, but the HSE and the Department of Health, and I know the Minister was actively engaged in intensive discussions with the manufacturers. So it has been delivered earlier than we thought. But essentially, Adam, I know it hasn't been ideal from anybody's point of view, but it has essentially been a factor of limited access to the stock.
Okay. So, you know, when we did finally get stock into the country, limited and all as it was, the portal was only open for a few hours when it opened first. Why did it have to close?
Yeah, unfortunately, we did have to close the portal. And again, that was simply because the number of appointments we could offer for the vaccine supply we had available became full. And I might just take 1 minute just to explain, because I know people probably aren't as close as us to it, sort of thing. So prior to that October portal opening, we had targeted a population who we had known had risk factors for monkeypox, which we estimated was approximately 600 people, those with early syphilis infections. So we were targeting that group in the first instance by the Sexual Health Services contacting. So we were using some of the stock that we had assigned for the that we had back for the post-exposure, but we had assigned for the pre-exposure, understanding that we then had a greater ability with this intradermal technique to actually offer those. So we were very much targeting. So we were using up some of our stock to make sure that priority group was given an opportunity for vaccination very early on in the program. And that was happening around August time. Then we entered into this phase of having largely contacted that group and invited them in for vaccination, and coupling with that intradermal technique, we estimated that we had stock for about approximately another 1,000 people using that intradermal technique. So look, I suppose we faced a kind of a decision point where we knew 1,000 vaccinations wasn't going to be enough for the community, but at the same time, we didn't want to leave that vaccination in storage. So our thinking was really it would be better to offer out vaccinations to people, knowing that it probably wouldn't serve the entire community, but at least giving people that opportunity to get on the vaccination journey. So the decision ultimately, I suppose, at the end of the day was to close the portal, because the worst thing we could find ourselves, or the worst space we could find ourselves in, was letting people book appointments where we weren't sure that we would have vaccination available. And ultimately, as you articulate, Adam, it was not a great experience from anybody's point of view. So look, I would like to personally apologize to the community for those who logged on and who couldn't get an appointment or couldn't secure an appointment. It was both frustrating and, more importantly, disappointing from their point of view. And I can only imagine how disappointed people were. So look, I just wanted to personally acknowledge what happened. But as I said, we were in that kind of context of trying to use the vaccination and try and maximize the opportunities, but understanding that was never going to be enough given the demand that's out there.
And so alongside, you know, the limited vaccine appointments and that having to close, there were also a bunch of technical issues with the website and when the portal opened as well. You know, looking forward to reopening the portal, and we'll get to that now in a sec. You know, are those things fixed? Are are we assured that when we, because I suppose when we put out calls to the community, and the community has a really good legacy of health-seeking behaviour and want to do the right thing, but when we come up against barriers of, structural barriers like this, it can be quite, it can result in disengagement, I guess, and I suppose that's what we all want to avoid. So those technical issues that kind of plagued the portal on the first day, have they been fixed?
Yeah, so I mean, you can obviously never 100% be assured of any technology, but we have exactly what happened during that first portal opening. Our eHealth partners have done a root cause analysis, and we've identified what the issue was in particular. And I suppose, again, just Adam, just to emphasize, when we opened the portal first, we were trying to get to vaccinating as soon as possible. So we probably didn't do as extensive the testing as we would have liked to try and get to that vaccination of the community as soon as possible. So since then, we've been obviously looking back at as to what happened and trying to test. So we're happy enough that actually those technical issues have been addressed.
So obviously we've heard a lot that the vaccine supplies are low across Europe, albeit though many other countries, have been able to secure what they've needed. Where are we now in terms of vaccine stock? How much does the HSC have?
So we have, well, we've received an additional 5,000 vials from the manufacturers, and we're very, very happy that will give us, with that intradermal technique, the ability to offer approximately 10,000 appointments out to the community. We might talk about that in a while, about when the portal opens, sort of thing. So we have an appropriate stock. We're due to also receive an additional donation from the EU sometime during December. Now, we don't have a confirmed timeline around that, but the most important message I suppose we're giving out today, Adam, is that for the current appointments we're going to be offering, we have the stock in place in order to carry out those vaccinations. And we'll talk about it probably in a while around what's the kind of timeline around that. But anything, it's our important principle is that if we put out an appointment, we want to be able to honor that with the stock that's available. So we're very assured that we have the current stock available for the appointments we're going to open up on Thursday.
So just before we get to that then, in terms of, we can talk about the numbers of people that are to be vaccinated, but so far, how many people have been vaccinated in Ireland?
Well, we've given out over 1,900 administrations of the vaccine to date. Now, we're just collating some of the information about how many that has actually had their second dose as well. But we'd estimate about 800 people have had both doses to date. And then there's obviously another further 1,100 who are on their way with their first dose. So, and everybody who's kind of has their first dose is booked in for their second dose. So we've had 1,900 administrations to date.
Okay, so there's 800 people possibly fully vaccinated out of an estimated kind of group of over 10,000.
Yeah, well, I suppose this is part of the issue from our point of view. We don't really have a good understanding of what the potential demand is going to be out there. So currently we've been in discussions with our public health. So our target at the moment is around, to make a meaningful public health intervention, is around 6,000 people we would like to have vaccinated. But maybe to kind of cover that off at this stage, I suppose, Adam, it's important for people to know when we get those additional EU donation stocks in, we are going to continue vaccinating for anybody who thinks they're at risk. So again, I saw one of the comments there a while ago that we might be dropping momentum. Far from it in the HSC. We're going to stick with this as long as we have stock and as long as we have vaccinating capacity. We're going to be able to provide. So my ultimate point is that no one knows exactly how many people out there actually want to get vaccinated, but we're going to continue in line with the NIAC recommendations to provide vaccinations as long as we have the vaccination stock and people are still out there at risk.
Okay, well, let's get to, I guess, the big question, which is, when will the portal be reopening? What can you share with us about that?
So I'm happy to say that the portal will open next Thursday, the 24th, from 10 a.m. And then we were going to be making approximately 10,000 of appointments available. Now, just to be clear with people, because people require 2 doses, that will translate into about 5,000 kind of doses. And the appointments will be available between Monday, the 28th of November, right up until the end of February 2023. Now, there's obviously a piece there just a week in Christmas time where the vaccination services won't be available, but appointments will be available across the country from the 28th, and the portal will open on the 24th at 10 a.m.
So just give us that again. There's 10,000
approximately on the system, but just to explain it for people, so that translates to be about 5,000 dose 1 appointments available on the system between November 28th and the end of February 2023 for people to look. And I'll do in a minute maybe where those vaccination centres are in a minute. But when a person comes in to have their first dose at the clinic, they will be booked into for their second dose. So some of the clinics we have to assign for those second doses. So those appointments are not available simply because of the fact that the way the process works is that you'll be booked into one of those clinics for your second dose.
So if the demand is high then with those 5,000 and the appointments are booked, you're saying that more will be added?
Yes, so I suppose to be clear and to be transparent, Adam, we will continue to review the demand. Now, in the HSC, we obviously have other vaccination requirements around COVID, flu, school catch-up, and a number of different nations. But we are working tirelessly to make sure that if the demand is quite high, where can we add additional capacity? And I suppose when you think about it, there's probably going to be two kind of demand situation or over demand situations, either totally across the system or in particular locations, whereas other places may still have capacity. So we're going to be dynamically reviewing exactly where the demand is, how much is capacity constrained in various different locations, and what can we do to add capacity. But again, to be transparent on some way, the capacity that we're putting out at the moment is for the vaccinations that we have in stock at the moment. Again, when the additional stock hopefully comes in December, we will have new stock in, which will allow us to extend out beyond February potentially. But in the intervening time, we will be able to look at to see where we could add additional capacity in various different locations.
Okay, so this Thursday, 10 a.m., all of those appointments will go live on that portal. It's hsc.ie/monkeypox, right? And that'll be every appointment then will be available up until the end of February. So before, when we kind of that first opportunity for the portal to open, there was mention of 11 vaccine centres, but seven were opened. Will there be 11 this time? And if so, where are they?
Yeah, so there's going to be 10 locations. Sorry, Waterford was one of the original places, but unfortunately, and that's because of it has an overall vaccination service in terms of its infrastructure just wasn't set up. So, so it's 10 locations, and I just named them out just so people have them. So in the Leinster area, there's going to be a capacity in the Mater Hospital, St. James's, St. Vincent's, Croke Park, and City West. And then more extensively in the Leinster area, that'll be Portlaoise and Wexford as well. And then across the country, it'll be Cork, Limerick, and Galway. So I might do that once more, just so people have it in their head. The three sexual health services of the Mater, St. James's, and St. Vincent's. And then we're going to have a large centre in Croke Park and in City West. And then the vaccination centres in Portlaoise, Wexford, Cork, Limerick, and Galway.
So the likes of Croke Park and City West, they're not sexual health services. That will be kind of like COVID centres, right?
Exactly. Yeah. But it'll be the same process for all kind of centres where people will, book their appointment and they'll come in, they'll be checked by a doctor, they'll be run through the eligibility criteria. So it's the same process regardless of where you have it.
So the majority of people will require 2 doses of the vaccine. And how will people get their second appointment? So obviously you're making the first appointments available on this portal this week. How did people get their second appointments?
So again, we're trying to keep the process as simple as possible for people. So when they come in, when they book their first appointment, just to say, people will get a text confirmation, so just so people understand, and within that then will be an ability for people to change or cancel that appointment. And so when they attend the services and they've had their first vaccination, then at that point their second dose is booked in for them. So there'll be a variety of times. So it has to be at least 4 weeks between the interval between your first dose and your second dose. But if people can't make it exactly 4 weeks, there will be other dose to clinics. So the administrative staff and the clinical staff in the clinic with themselves will sit down and find what's the right time for the person in terms of their second dose. So nobody needs to worry about kind of booking their second dose when they're actually on the portal booking in their first dose.
So you get your vaccine, you're not leaving the vaccine centre without an appointment for your second dose.
Yeah, exactly.
And so then things as they do crop up, and folks might need to cancel or rebook their appointments. How do people arrange that?
So it's slightly different for the first dose versus the second dose. So with your text message, you'll be given a link to how you could cancel your first dose. But in your second dose, obviously, we said you sit down and you agree a date with the clinic service themselves. So to cancel you then get a text message confirming your second dose when it's booked in the clinic. And within that then will be an ability for you to cancel your second dose. But then if you wanted to get an actual second dose booked in because there isn't an ability for you to go back onto the portal, what we're recommending is that people contact HSE Live, and HSE Live will be able to book them in, or else we will be also introducing a process where we will be reaching out to people who have cancelled, or there's also another category of people who mightn't have attended on the day. So we'll be following up those people to ring them to see, do they want to book another appointment? And if they do, what would be convenient for them in terms of those 2 clinics that are available. And
so this online portal is available to people who meet the criteria, anybody that feels that they need a monkeypox vaccine, but that's for people over 18 only, right? So obviously people are sexually active under 18 in our community. How do those people book an appointment?
So those people who book an appointment again through HSE Live for a number of different reasons. But yeah, just to emphasize again, people under 18, between 16 and 18 can get a monkeypox vaccine. And what they will do is ring HSE Live. So again, when you go onto the booking portal, that actually is said on very clearly in the booking portal that if you're between 16 and 17, you should actually contact HSE, and the HSE Live number is up there. So when you ring there, they'll take your details, and then someone from one of the clinics will ring them, that person, to agree an appointment date with them.
Okay, I think we've covered a bit there, and I know there'll be questions in a moment. Is there anything else that you feel that you need to add, or that is?
If you wouldn't mind, just 2 things, Adam, just very quickly to say. Number 1 is that, the WHO is not recommending a mass vaccination of the community, but in that context and in line with the NIAC recommendations, anybody who feels that they are at risk should come forward for a vaccination. But we're mindful of keeping the prioritization for those at risk. So look, we would ask people to make sure that they are appraising themselves against the risk criteria to make sure that we're targeting the right population. And I suppose the second thing, just to acknowledge, Adam, yourself and Pádraig have been on the National Crisis Management Team and the vaccination programme with us. And just the community mightn't know, but just to acknowledge all of the work and the professionalism of Adam in the work that he's done with the NCMT and the vaccination programme. I can assure you folks that Adam, I could use a less polite term, but he's been unrelenting in terms of asking us the hard questions about when, where, how many, how fast. So I just want to pay due acknowledgement to both Adam and Pádraig for the work and the representation, the professionalism that they show in the representation on our NCMT. We're just very, very grateful for the partnership approaching.
I appreciate that, Kieran. Thank you. So look, I think we're coming up to 10 minutes to the hour, so I think it'll be important for us to open it up to folks that are watching live to answer some of their questions. And we might bring Eve and Cathal back in if we can. Great. So so let's have a quick look through the questions here. Well, one from Chris Noon there, simple one. Is the booking system available in languages other than English?
Unfortunately, not. Irish is the only other language, because again, we were focused on making sure we could try and get operationalized as quickly as possible. Unfortunately, it's not.
So all of the work that we kind of put out is always translated into a number of different languages. And I suppose what we make sure is that our outreach team will also be available to support people where English isn't their first language and maybe navigating the system. So while the system might not be available in other languages, we're definitely there to support people through it. So if we can get that word out too, that'll be useful. Cathal, did you have something to add there?
Yeah, I might just add as well that obviously we run a lot of the vaccine centres run their own clinics as well. So if we have someone who doesn't speak English and who isn't going to be able to access the vaccine booking system, we're happy to link them in through our own services as well. So there's other mechanisms to support these people.
Thanks, Cathal. So there's a couple of comments just around the number of vials and doses that you mentioned, Kieran. So you might just clarify that again in terms of how much stock we have, but how much that translates into actual appointments and bums and seats.
Because that's an important clarification, because I know Cathal was kind of mentioning the 5, but just again to say to people, even though sometimes the multiplier is 5, again, for some cohort of people, they're going to be getting this subcutaneously. And then, just the way the operations run, at the end of the day, even though you might have had a vial, there's always some wastage associated with it, even though all the clinics try to maximize every single drop of the vaccine. So conservatively, we use a kind of typical multiplier of around 3 to kind of give us an estimation as to how many vaccines we could actually realistically get from the different vials. Because again, as I said, some of the stock is being used for post-exposure, where you just do one person sometimes. So people come into the clinics and they need to be applied subcutaneously. So again, from our point of view, we're using that kind of multiplier of 3 to kind of give us an estimation. And then when you take the double dose, so that would give us a stock of about 7,000 vaccination that we should be able to apply. And so we're kind of putting out the 5,000 to 6,000 currently at the moment.
Carl Hayden has asked, what public information campaign will the HSE engage in to ensure people know the vaccinations are available and what the limitations of the next phase will be?
I suppose, number one, we're very glad to partner with Adam and POWER and a lot of the organizations to promote, and we feel that that's one of the best methods is the direct communication to the community. Obviously, we are going to be providing any information, and our website has various information available about the vaccine that we can provide, and so that'll be online.
Pete McGuire has asked, I guess, just about the ability for other European countries to be able to access stocks, I guess, ahead of us, and why we weren't maybe at the races for that.
It's very hard for me, Pete, to talk to what other European countries did. I know we were very, very assertive, and we were very, very quickly off the blocks in terms of requesting vaccinations and trying to procure those from the manufacturer. And I know there was a lot of engagements. I can't talk to what other European countries did in that space, but I know there was, a lot of communications and a lot of requests to the manufacturers to get our hands on a stock as quickly as possible.
David Wallace asked just do we have any stats on the level of vaccine uptake, which I think you mentioned, or projections onto what the level of demand is compared to the current uptake. I suppose it's a difficult question. It's a Thursday morning demand question, really.
It is sort of thing. And look, just assure David, I mean, again, I think the opening of the portal on Thursday will give us such a huge information as to what the demand is like, and more important, and as importantly, where the demand is. So we're going to be dynamically keeping an eye on that to make sure we're looking to see our appointments being constrained in any particular locations, or is there availability that we need to add to. So look, I suppose, David, to be very quite honest, none of us have any idea about what the true demand rate is going to be. But again, it's something we're going to be keeping a very careful eye
on. John Gilmore has asked, I'd like to know why crisis management team has not acknowledged the massive financial impact monkeypox isolation can have and recommended to government specific financial support as advocated by the community.
And thanks for that, John. And look, number one, to say we have, so we're on the CMO has started a strategic advisory group associated with monkeypox vaccine, as people might be aware of. It is one of the issues that we did raise with them. And I know the minister, I think, has written to the Minister for the Department of Social Protection in respect of exactly that issue. So we're waiting to hear back. So it is something that we were conscious of, the needs of trying to keep yourself isolated, but at the same time, the impact financially on a particular person.
I think that covers off the questions that have been put in. If there's any other questions for anybody, I think maybe I might give you all an opportunity just to kind of maybe add a comment onto what you think is the biggest priority in each of your kind of areas of expertise. What's the biggest priority or the biggest next step for monkeypox and the response? What's kind of the most important thing? Kieran, I might start with you.
Being very brutally honest, seeing this through, to be quite honest with you, that's my, like, I totally appreciate exactly what the community needs and wants. So from my point of view, seeing this through to the end and making sure that and obviously we're conscious of the NIAC recommendations, but seeing to make sure that anybody who feels that they are at risk can get access to a monkeypox vaccination.
Cathal?
So I won't repeat what Kieran has said there. So I think from our angle, I think understanding the disease and vaccination better from a scientific perspective. So, for example, can people have monkeypox infection and no symptoms at all? That we've seen in some studies in France and Belgium that they found some people who had the presence of some DNA on swabs, but they didn't have any symptoms or weren't able to recollect when they looked back their history. And then looking at the vaccine, so how long is the vaccine going to last? What are the best ways to give it in the future? How can we best support the community going forward with any vaccine strategy? And all of that research is being done through some of the clinics. So here in UCD and Convinced Matter, we're working with the All Ireland ID course. James, they're coming on very shortly. And we'll be asking a small portion of our patients if they would like to donate a sample of blood to this kind of research effort as part of a European-wide collaboration to understand monkeypox virus and monkeypox vaccination. And there's been really, really positive, strong uptake from the community. And there always has been when it comes to research and trying to figure out the answers to these really difficult questions. So thanks to everyone who's been involved so far.
Thanks, Cathal. Eve?
I think, and it's been mentioned before, that we don't become complacent with the low number of cases and we continue our coordinated efforts to respond, including really strong community engagement, so that we have activities across the whole spectrum of management, from people being aware and recognizing their symptoms to accessing testing, contact tracing, supporting people to isolate when that's required, and vaccination.
Great, thanks. And I think all in all, I think, the community has been really, really engaged from the very, very start of this outbreak. And I think, it's real. It really is very, very much testament to how invested we are in our sexual health and our well-being, and long may that continue. And I think, it's been great that we've been able to be at the table and, as Kieran said, ask and push the hard questions and get those results for our community. And I think community will continue to be a really important part of the solution. And when we do get to a point where, we need to think more creatively about how to get vaccine in arms and not shut up shop, we'll definitely be at the table for that. I might also add that alongside what Cathal has mentioned, we'll at MPOWER be leading out some community-based research on the monkeypox response to date, where we can learn about the positives and the negatives, but also to better understand how we can continue to respond to the needs of our community, so that we're developing services and resources that work for you. So we'll be putting out a call for people to respond to that. It'll be a fairly short survey that can be done online. So do keep an eye out for that. And I guess just to end on the fact that be ready Thursday 10 a.m. for access to your monkeypox vaccine. And please do, either through social media or WhatsApp and email and all the different ways that you can reach out to MPOWER. Please do on the day and throughout the rest of this outbreak and onwards. If there's anything that you notice, we're obviously very quick into the likes of Kieran and the team at the National Crisis Management team to make sure things get fixed and that we get access to the monkeypox vaccine as we need it. So look, I think that brings the event to a close. I just want to thank again Eve, Cathal and Kieran for their time this evening, and for everybody for tuning in, and for our pals at GCN for always producing a very slick show. Thank you very much, and have a nice evening.